an option for healthcare, but a superior one in terms of health outcomes and ethics as well. So this Bloodless Medicine and Surgery Week is organized by the Bloodless Medicine and Surgery Group in the University of Calabar. And this is a collaboration with the Bloodless Medicine and Surgery Society, the Society for the Advancement of Patient Blood Management, otherwise known as SABM, and the Malaysian Society for Patient Blood Management. The theme for this year's week for 2024 is Bloodless Care in Oncology and Palliative Care. I am pleased to introduce my co-moderator with me today, Dr. Christopher Simotu, who's a fellow of the Royal College of Surgeons of Ireland in Edinburgh, and who's a general surgeon working in Zambia and the president-elect of the Bloodless Medicine and Surgery Society. Good morning, Chris.
Good morning. Thank you very much. I would like to also welcome you all to the Bloodless Medicine and Surgery Week for this year, 2024, whose theme is Bloodless Care in Oncology and Palliative Care. This week, today, we will listen to two interesting talks by seasoned clinicians. The first one, which is the keynote address, is on the scientific evidence against blood transfusion in oncology. The second one is a talk on palliative care in oncology, the nuts and bolts. If you look in your program, there was also supposed to be a third presentation, which will be done on Friday. But before we go to the keynote address, let us get some welcoming remarks from the organizers. Let me invite Dr. Nathaniel Usoro, a general surgeon, who is the chairman of the Bloodless Medicine and Surgery Group in University of Calabar, Nigeria, and he is also the president of the Bloodless Medicine and Surgery Society, to make his welcome address. Dr. Nathaniel.
Thank you so much, Chris. It is my privilege to welcome everyone to the Bloodless Medicine and Surgery Week 2024. As Dr. Simotu had pointed out, the month of May is Bloodless Medicine and Surgery Awareness Month, meant to raise awareness of the superior clinical outcomes of bloodless medicine and surgery, which is defined as the provision of quality medical care without the use of allogenic blood, with the aims of improving outcomes and protecting patients' rights. Within the month of May, the Bloodless Medicine and Surgery Week is a special week dedicated to this task of raising awareness. It always incorporates May 16, which is the World Bloodless Surgery Day, an initiative of the Bloodless Medicine and Surgery Society to commemorate the first bloodless open heart surgery by the father of modern bloodless surgery, Dr. Denton Cooley, who on May 16, 1962, carried out his very first bloodless open heart surgery. That was 62 years ago. Incidentally, Dr. Cooley grouped his techniques under 3 pillars. And those very 3 pillars are the pillars which the World Health Organization is now popularizing as the pillars of patient blood management. It all started from bloodless surgery. So bloodless medicine and surgery started as an advocacy to accommodate patients who decline blood transfusion. But the superior outcomes in non-transfused patients of all categories became apparent over time. At the same time, the adverse outcomes of blood transfusion in all categories of patients became apparent too. Hence, the emphasis on transfusion avoidance, which today is being advocated all over the world by the WHO in a recent policy brief to avoid blood transfusion and to improve clinical outcomes while also protecting patients' rights. As Dr. Simotu told us, the theme for the Bloodless Medicine and Surgery Week 2024 is Bloodless Care in Oncology and Palliative Care. One of the areas in which the adverse outcomes of blood transfusion were first studied is oncology. Starting from today, we are going to listen to some of the best clinicians and academicians in the world who are experts in these fields. They'll be sharing their knowledge and their work in this area and discussing how we can avoid blood transfusions when caring for cancer patients in order to improve outcomes. Palliative care is an important part of oncology and has a bearing also on outcomes. This will be discussed as well during this week by some of the world's leading experts in this field. The World Bloodless Surgery Day, Thursday, May 16, is going to feature a lecture on bloodless liver transplant by the president of the Ibero-American Society of Patient Blood Management. They are also working with us on these webinars. On Friday, we will hear from patients themselves, patients who have experienced bloodless surgery and their thoughts on the practice. And the week will conclude on Saturday with a talk on bloodless care in uro-oncology and a quiz to exercise our minds on some lessons learned during the week. This week is made possible by a collaboration between the Bloodless Medicine and Surgery Group in the University of Calabar Teaching Hospital in Nigeria, and the Bloodless Medicine and Surgery Society, the Society for the Advancement of Patient Blood Management, and the Malaysian Society of Patient Blood Management. As I mentioned, with technical assistance from the Ibero-American Society of Patient Blood Management. Many of the speakers, moderators, and panelists during the week are members of these organizations, and we thank them all very much. We are particularly grateful to all the speakers who created time out of their very busy schedules and expended much effort to prepare the talks and participate in the program to save lives and improve patient care all over the world. None of them is paid for this. So it is truly a labor of love on their part, for which we are very thankful. We also thank all the moderators, panelists, and committee members of Bloodless Medicine and Surgery Week 2024. Of course, without the attendees, all the effort would go to waste. So a big thank you to all attendees who made out time to attend this webinar. We are confident that by the end of the week, we will have acquired the basic knowledge and confidence to improve clinical outcomes of our patients and protect their rights through the application of bloodless medicine and surgery techniques. Thank you all very much for listening.
Wonderful. Thank you very much, Dr. Osoro. It is my pleasure now to introduce the president of SAVM, Dr. Carolyn Burns, to provide her address this morning.
Thanks, Becky, Chris, and Nat. Really appreciate the opportunity to be here. Can you all hear me okay? Okay.
Very well.
Yeah, this is a wonderful conference that's being displayed this week, and I want to thank the faculty, international faculty, the planning committee, and all the attendees, as Nat mentioned, that have taken the time out of their busy clinical schedules to be a part of this. This truly is a joint effort that's been a long-standing collaboration between our societies, and it's an exemplar of those synergies and alignment that we all share to secure this global implementation of patient blood management and what we're now addressing as the overarching concept of blood health. I found this year's theme to be very intriguing and very timely, as I think we are all seeing the arena of oncology and palliative care expand in some ways, sadly enough. And we are fraught with very distinct, very complex medical and surgical decisions in the diagnosis and management of these patients, and in particular, those ethical considerations that are necessary for us to be able to provide compassionate care and at the end of life. So it's a real honor, by the way, to be the current president of SAVM, and thus an honor to invite everyone here. I hope what we're going to do is all listen, learn, question, and discuss how PBM must certainly be the standard of care, not only for oncology and palliative care patients, but for all patients around the globe. So thank you so much, and I'm going to turn it back to our moderators to get things started.
Thank you very much, Dr. Burns, for your remarks. It's always a pleasure to have you on our program. I would like now to calling the president of the Malaysian Society for Patient Blood Management, Dr. Mandi Yap. Your floor.
Oh, thank you, Dr. Simotoe. Hi, everyone. I'm Mandy, the president of Malaysian Society of Patient Blood Management. First of all, I would like to thank Nathaniel for inviting me to this Bloodless Medicine and Surgery Week 2024. And I feel very grateful that if it is not the previous president, Dr. Jamila Sattar's wonderful work, who has paved the way for my PBM society to be able to collaborate with so many other societies to jointly organize this meaningful event. And I don't think I'll be able to meet up with so many prominent experts in this field. PBM is a multidisciplinary team approach effort to improve patients' outcomes. Last but not the least, we're going to have a lot of exciting topics, including those controversial fields like you have heard from Dr. Burns on oncology as well as palliative care. Please do join us and make this event a success. Thank you very much. Over to you, moderator. Thank you.
Wonderful. Thank you so much, Dr. Yap. We really appreciate having you join us today too. I would now like to introduce Professor Ngum, the Provost of the College of Medical Sciences, University of Calabar, Nigeria, who's an orthopedic surgery and a founding member of the Bloodless Medicine and Surgery Group at University of Calabar, and a member of the Bloodless Medicine and Surgery Society, to please make his address to the group this morning. Take it away.
Oh, I'm sorry, we send his apologies. I think he'll be joining us later. So I think we'll go straight to the first keynote.
Okay.
And all right, thank you very much. Before we start our keynote address, I'll call upon Sheila Faustin, who is a nurse coordinator in Bloodless Medicine and Surgery Program of MedStar Health, Washington, D.C., USA, to come up with some housekeeping for the meetings we're having. Sheila?
Thank you, Chris. Hello, I'm Sheila. I have some housekeeping rules and information to share with you this today. Happy Bloodless Medicine and Surgery Week. All questions should be placed in the chat. Minimize chats so that we do not distract the attendees and speakers. The program will be live streamed on BMS's YouTube channel if anybody has difficulty with Zoom. Again, thank you for joining. Happy Bloodless Medicine and Surgery Week.
I think Sheila meant to say that questions should be put in the Q&A, not in the chat.
Yes, sorry, Q&A.
It is now time for our keynote address by Dr. Neo Bloomberg. Dr. Neo Bloomberg is the director of the Transfusion Medicine Division and Blood Bank of an 880-bed university hospital and professor of pathology and laboratory medicine at University of Rochester, New York, USA. He received his BS and MD from Yale University in New Haven City and had his residency training in laboratory medicine, hematology, blood banking at Yale New Haven Hospital. Dr. Bloomberg's particular interest is in transfusion immunology, having participated in research into the previously unappreciated immunological effects known as transfusion immunomodulation. His clinical interests are in the diagnosis and treatment of immune disorders, such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, supportive care for stem cell and solid organ transplantation, and mitigating transfusion side effects through leukoreduction, use of autologous transfusions, and the removal of stored supernatant through washing. His group, co-led by Dr. Joanna M. Hill, MRCP, described the ill effects of transfusing ABO incompatible solution antigen antibody. Dr. Bloomberg is a member of several professional societies, including Bloodless Medicine and Surgery Society and the Society for the Advancement of Patient Blood Management. And he is in the Hall of Fame of the Association for the Advancement of Blood Biotherapies. May I call upon Dr. Neil Bloomberg, please?
Thank you so much, Chris. See if I can share the appropriate screen here. Can everybody see the slides? Okay, so one thing I should say is I am not an active medical or surgical oncologist or palliative care physician. I'm a hematologist and clinical pathologist, and my primary responsibility obviously is for transfusion medicine, a very small part of the care of patients with cancer or any other disorder. But unfortunately, transfusion has sort of become embedded in the clinical practice of many oncologists, surgical or medical, over the decades, so that they looked at it very casually. And there are obvious, for those who take care of patients, for example, with acute leukemia, it's clear that there are some patients who are very hard to manage, if not impossible, without using transfusion. But what we're trying to address over the last 30 or 40 years is that we need to move to a bloodless model when that's possible, and certainly to reduce the use of transfusions when absolutely essential to an absolute minimum. And I'm going to try to discuss some of the scientific and clinical background to that. Starting about 40 plus years ago, it became clear that patients with solid tumors in particular, any type of cancer that was a solid tumor, who was transfused during the early part of the therapy, usually involving surgery or radiation therapy, that these patients did much worse in terms of disease recurrence. And in fact, we have not had randomized trials except for one or two that I will show you that answer the question, is this a cause and effect? Because it's very hard to determine cause and effect just from observational studies. But some of the risk ratios are in the 4, 5, 6-fold increase in recurrence, which are very unlikely to be explained by mere association or confounding. I will show you data from leukemia patients where we've been able to intervene and change the prognosis that suggests that transfusion is in fact causally involved in increased tumor recurrence, at least in the liquid tumors like the acute leukemias. But most of this talk is going to focus on things that happen to patients when they are transfused that are unfavorable other than tumor recurrence. So I'm going to start actually at the end of the story, which is that we know that transfusions have profound effects on immune function. And as you can see from this summary that was published 30 years ago, it's a very, very long laundry list of immune modulation. The immune modulation is not well accepted in the field of transfusion medicine, and perhaps not in hematology, but it's very real, and this has been demonstrated in animal models and in patients. And none of these things are favorable if you have cancer. I'm not going to go down through the list. You can read it at your leisure or in the original paper. But they all involve decreases in cellular immune function, upregulation of, in general, humoral immunity, decreased cytotoxic function. And now we have modern therapies like CAR T cells, chimeric antigen receptor T cells, which are autologous gene-modified therapy that many of you are familiar with in lymphoma, particularly in multiple myeloma and acute B-cell leukemia. What we have seen is that the patients who require transfusions after CAR T-cell therapy have much higher rate of cancer recurrence. So transfusion in this setting is a problem as well, even though I think immunotherapies are, in fact, the future of cancer therapy. It's hardly an original idea on my part. So this is a schema that was published some years ago in Transfusion, and it's meant to emphasize the fact that transfusions are the worst of both worlds. They not only impair cellular immunity, which impacts things such as cancer recurrence, but they also cause inflammation. Transfusions of red cells and platelets are pro-inflammatory. They impair the ability to clear infections, which are very common, obviously, in cancer patients. They impair wound healing after surgery, and in general contribute to organ dysfunction. And one of the schemas shows that, in fact, type 1 responses, cellular immunity, are inhibited by transfusion, and type 2 responses, which are antibody responses, are in fact promoted. And antibody responses don't really help much in cancer, as it turns out, where cellular immunity is very important. And in this animal model, the late Wesley Alexander and his group showed that type 2 cytokines like IL-4 and IL-10 are in fact increased, and IL-2 decreased after transfusion in animal models. So there are a number of these type 1 responses that are antagonized, and then for example, they will inhibit allograft rejection. Kidney patients who've had a kidney allograft will have better organ survival if they're transfused. We can also treat the rejection of fetuses and allograft, and some inflammatory diseases may actually benefit from transfusion. But in fact, antibacterial immunity, anti-tumor immunity, antiviral immunity are all impaired by transfusions. So to give you an idea of how this works in patients, this is a randomized trial done by Jill Cholette in our institution, published some years ago, in which we looked at wash transfusions with the hypothesis that the stored supernatant plays a major role. And I'll show you some data from leukemia later. But in this pediatric cardiac surgery population, which obviously is not cancer, what we found was that wash transfusions mitigated some of the inflammatory response. IL-6 levels post-operatively in the wash transfusions groups were considerably less so than in the unwashed group. So this shows in a randomized trial that the inflammation of transfusion can be mitigated in part by, in fact, washing, which is a very unpopular approach in the United States. In fact, there's an enormous prejudice against the idea of washing, but it has the potential to make transfusions, when necessary, considerably less harmful. In terms of cancer after transfusion, there are some data from epidemiologic studies that, in fact, blood transfusions may, in fact, lead to long-term immune changes and other changes that have led to an increase in cancers. So this is a United Kingdom study of women who received transfusions for non-cancer diagnoses. And then after 8 years, for example, the rate of liver cancer was about 3-fold higher. The rate of non-Hodgkin's lymphoma was about 2-fold higher. So we don't know what this is, whether it's immune modulation or unknown viruses or in the transfused blood, but transfusion may be associated with long-term risk of increased cancer. And this is some of the other data from that study. And it looks like, in fact, that patients who had surgery for colon cancer, for example, had a 4-fold increase of recurrence. And if you look at non-Hodgkin's lymphoma, a 5-fold risk of recurrence, and in leukemia, a 7-fold increase. So there are some tumors that don't seem to be affected, thankfully, such as breast cancer. But in fact, transfusions are at least epidemiologically associated with increases in recurrence rate in cancer patients who undergo surgical or other interventions. And perhaps the most convincing data from Marcus Heiss in Germany, from almost 30 years ago, published in the Journal of Clinical Oncology, is he randomized patients to receive autologous transfusions, which we now know from many years of work, are not as immunomodulatory and may actually be immunostimulatory. And in fact, the patients who were randomized to autologous blood had considerably better recurrence rates. And this is tumor-free survival in patients who only got a few units of blood, less than 2 units of blood. And as you can see, the autologous group, albeit a small study, did statistically significantly better than the allogeneic group, which adds to the data that allogeneic transfusion in cancer is a double-edged sword. It may relieve symptoms, it may prevent certain problems, but on balance, it's really not good for cancer patients. It's bad for cancer patients. And when you give, for example, platelet transfusions, this is a study done a number of years ago in our institution, patients getting prophylactic pre-procedure platelet transfusions had a very high rate of mortality over the succeeding 30 days. Obviously, some of this is because they were very sick, but some of it may be because of the immunomodulatory effects of platelet transfusion, and the patients who died of inflammation and septic shock by and large. So one of the very important problems that oncologists have been dealing with now for some time is cancer-associated thrombosis. And this was actually brought to the attention of the medical community, mostly through the work of Ala Khurana, who was a colleague here in Rochester for a number of years. He's now at the Cleveland Clinic and has been one of the world's leaders in studying the issue of thrombosis in cancer patients because it's a common problem. Thrombosis is associated with inflammation and with cancer, and obviously autoimmune diseases. And in fact, there are obviously patients who are on aspirin or anticoagulants have a lower rate. So the question is, what is the problem in cancer patients? And this is a model that I've stolen from a Canadian presentation on the subject, but patients with various cancers do seem to be at increased risk during their treatment of thrombosis. And this is primarily deep vein thrombosis and pulmonary embolus rather than arterial thrombosis, but arterial thrombosis is probably also increased. So what is cancer-associated thrombosis? Obviously, a patient with cancer who develops a venous thromboembolism, and it's actually quite a striking increase, 4 to 7-fold. It can occur early on, it can occur late, but it's most frequently diagnosed in the first few months after cancer. And this is a common complication, obviously, and we do have some treatments, and we're just beginning to, when I say we, I mean oncologists who are interested in this subject, rather than myself personally, explore which patients should be anticoagulated. And I'm sure you're all familiar with the different types of thrombosis, particularly deep vein thrombosis in the legs and the pulmonary emboli. It's rarer in the arms, but with catheters in place, that can increase the risk. So it turns out, and Ala Khurana and many other colleagues throughout the world have shown that this is actually a very common cause of death in patients with cancer, second only to direct cancer-related deaths themselves. It's the second leading cause. And that patients who develop a venous thromboembolism have higher mortality overall. And it can certainly become problematic for continuing treatment of the primary tumor. So about 1 to 12% of patients develop a thromboembolism, but cancer, it varies from disease to disease. And in fact, fatal pulmonary embolism is the leading cause of sudden death among hospitalized patients, and this includes cancer patients. And the same things is true of cancer patients. And so with this graphic shows that much of this is undiagnosed until after death or at the end of life. And this is just some graphs showing the actual probability of death in patients with no hospitalized patients no cancer, and no thromboembolism, cancer alone. And when you add thromboembolism to patients who have cancer, the probability of death really goes up quite dramatically. This slide just demonstrates that the rate of thromboembolism seems to be increasing, probably because we're successfully treating cancer patients, keeping them alive for longer periods of time, and so they're at risk for longer periods of time. And obviously, most of these events in surgical patients, whether they're cancer patients or not, tends to occur fairly early after surgery, which is the major risk factor, but can be quite delayed. So the balance between bleeding and thrombosis is something familiar to all of you. We like to keep patients in this range where they're hemostatically functioning, they're not bleeding, they're not thrombosing. Turns out that the ABO blood group may play a role in this. Patients who are type A and type AB have higher rates of thrombosis. Type O have lower rates of thrombosis. Conversely, patients who are type A, B, and AB have lower rates of bleeding, and patients who are type O have higher rates of bleeding. But it turns out that what your blood bank is doing may greatly affect these things. Unfortunately, dogma has arisen in blood transfusion that ABO blood group, which is important for red cells in transplantation, does not matter for platelet transfusion. And unfortunately, this is total nonsense. There are randomized trials showing otherwise. It's very difficult to give ABO match platelets to patients because we can only store them for 5 to 7 days. And in fact, Laura Cooling did a study some years ago, showed that 40% of platelet transfusions in her institution were in fact ABO non-identical. So the problem is that ABO mismatched transfusions are associated with platelet refractoriness, increased bleeding, multi-organ failure, and increased mortality in observational studies, and that, in fact, they make things worse in cancer patients. They also cause a wide range of relatively minor reactions, which are only minor to the blood bank director, not minor to the patient. And in fact, in randomized trials, Robert Carr in England many, many years ago, 34 years ago, showed that platelet refractoriness was about 10-fold higher in this small study of platelet transfusions in patients with hematologic malignancies. They made more HLA antibodies. They made more antiplatelet antibodies. And this is just data from our own group showing that patients who receive ABO non-identical transfusions, which we no longer give to patients and haven't since about 1992 for hematologic patients and since 2005 for everybody, that bleeding is much more severe in recipients of ABO non-identical transfusions. And in fact, it does appear that the prevalence of major bleeding episodes is only about 5% in hematologic malignancy patients who get ABO identical, but that in the literature, 15 to 20% of patients bleed. And in the Plato study, a randomized trial done some years ago, they had a 70% bleeding rate, so almost 12 times higher than if you give ABO identical platelets. So we know from in vitro modeling that platelet dysfunction and generation of thrombin is impaired by anti-A platelet antigen interactions. Clot formation is not normal. And now we have some data from Colombia that's been provided in abstract form at this year's ASH, showing American Society of Hematology that in fact that ABO immune complexes from transfusion can cause vascular injury that leads to bleeding in the head. So we've shown in randomized trial that when we give ABO identical, leukoreduced, and wash transfusions, we have substantially better survival in our patients. So we can mitigate this. We can't make this effect go away. on survival. And this is the randomized trial data showing that washed transfusions are significantly better than unwashed in younger patients with acute myeloid leukemia. And this is comparing our data in these younger patients with the New York State data, which from the Cancer Registry. As you see, we have a 20% mortality rate at 5 years versus 50%. This is not a randomized trial, obviously, but these are really striking differences in clinical outcomes. So we know that transfusions are, in fact, associated with infection. They're associated with thrombosis and cancer recurrence. These are not good things. And so in cancer, we believe that it's really quite important to try to minimize transfusions or use, if possible, bloodless medicine techniques, because transfusions are really predisposed to a wide variety of bad outcomes, including mortality, that using restrictive transfusions or autologous transfusions can reduce this effect but not make it go away, that we can use leukoreduction and washing to reduce some of the side effects. But once again, mitigation is not the same as abrogation. So if we can avoid transfusion, that is by far the best outcome for these patients. And if we have to use transfusions, we should use them very conservatively, and they should be leukoreduced and ABO identical. I'm going to finish this talk just by acknowledging some of my collaborators over the years. My most important collaborator is Dr. Joanna Heel, who co-led our research group. Joanna and I have also shared a couple of mortgages and a couple of children and one grandchild. So it's been a very important part of this research, and I don't want to pretend that I was the key person by any means. Some oncologists and hematologists, Dr. Rowe, now in Israel, Dr. Liesfeld at our institution, Gordon Phillips, who was head of our stem cell transplant program, and Ala Corana's mentor, Dr. Charlie Francis, one of the world's experts on hemostasis thrombosis. Folks in the blood bank, Dr. Majid Rafai, who you'll hear from tomorrow, and is on the panel, our chief supervisor, Debbie Maisel, and one of our technical staff, Kelly Hendricks, and a wide variety of other clinicians and basic scientists. And very grateful for the opportunity to address this group. And I will stop my screen sharing now.
Wonderful. Thank you so much, Dr. Bloomberg. Always very informative and very entertaining. So to our attendees today, please remember that you can place your questions into the Q&A section at the bottom of your screen, and we will do the Q&A session after all of our speakers are completed today. So next, I would like to introduce Dr. Evelyn Taiwo, who is an associate professor of medicine at Weill Cornell Medicine, an attending physician, and a director of the Hematology Oncology Fellowship Program at New York Presbyterian Brooklyn Methodist Hospital. After completing her medical training at Temple University School of Medicine and residency at Boston University Medical Center, Dr. Taiwo completed a 3-year fellowship in hematology and oncology at the University of Texas Southwestern Medical Center in Dallas, Texas. She's previously served as an assistant professor of medicine at the State University of New York, Downstate Medical Center in Brooklyn, and an attending physician at Kings County Hospital. While at Kings County, Dr. Taiwo served in a leadership role as a director of the Breast Cancer Center, overseeing operations, research activities, clinical care delivery, and education. So in addition to clinical care, Dr. Taiwo's work addresses disparities in breast and healthcare with a focus on improving clinical trial enrollment, community engagement, and patient advocacy. As a researcher, she's contributed to several studies on cancer presentation in urban and minority patient populations. So Dr. Taiwo's talk today will be entitled Palliative Care in Oncology, the Nuts and Bolts. Welcome, Dr. Taiwo.
Thank you. Thank you so much. And happy Bloodless Medicine and Surgery Week. I will share my screen. And I will start the presentation. Can you all hear me and can you see my screen?
Very well.
Fantastic. So as Rebecca mentioned earlier, I'm a medical oncologist. I actually with an expertise and focus in breast cancer. So I am kind of out of my realm here, but this was it's an honor to be here talking about palliative care. You know, I work in Brooklyn, New York, and prior to moving to Weill Cornell Medicine, I worked at a safety net hospital called Kings County, where a majority of my patients were underserved immigrant patients, mostly from the Caribbean. And I say this just to talk about what really piqued my interest in palliative care in cancer. Many of my patients would come in with metastatic disease. They were coming in with incurable cancers, but treatable, but incurable. And, you know, the need to focus on how to manage, how to care for these patients, but also making sure that the toxicity of the treatment didn't really outweigh the benefit of the treatment that we were giving. And that's how I came into palliative care as a medical oncologist. I have no disclosures today. And, you know, when I got the invite to give a talk here, I wondered, I said, well, what does palliative care have to do with bloodless medicine and surgery? And I kind of did a little bit of a deep dive myself into bloodless medicine and just kind of understanding it. Bottom line, it's very medical. It's this, you know, first do no harm, right? In everything that we do, that really is the underlying charge, and which exactly is what palliative care is as well. And it made me understand this connection between why giving this talk on this platform was important. So for the rest of my talk, I'm going to just focus a little bit on just what palliative care is, the goals of palliative care, who is eligible, and some of the palliative care interventions that are important, particularly, patients who have been diagnosed with or living with a cancer diagnosis. It's a very, very basic question. What exactly is palliative care? There is a lot of myth about and confusion, not just with patients, but doctors as well, about what palliative care is. People hear that word and there's a concern that, oh, that means there's there are no treatment options. You know, when you're talking to a patient about palliative care, the fear is that you're getting to a point of their treatment where you're suggesting that we do absolutely nothing for their disease, which is completely far from the truth of what palliative care is. But palliative care is, you know, it's been defined by the Multinational Association of Supportive Care as supportive care in cancer, which is just the prevention and management of adverse effects of the disease itself. That's cancer, and then the treatment of cancer, which could be chemotherapy, could be immunotherapy, could be targeted agents. It's a focus on management of physical and psychological symptoms of the side effects across the continuum, right? So not only is it an intervention that should or is offered at the end of a patient's life, but it's a service that really should be provided to patients from diagnosis through treatment to the post-treatment phase. And its focus really is on enhancing rehabilitation, secondary cancer prevention, even in the survivorship phase when patients are no longer with active cancer. But of course, the end of life care is a huge part of what palliative care is. So all of this is what encompasses what palliative care is. It's really just supportive care, managing physical, psychological, emotional, spiritual from the time of diagnosis to the time of death for the patients who succumb to the disease. This is a nice cartoon that shows what, you know, it all means when we talk about palliative care, when we talk about supportive care, when we even talk about hospice, because those things really do get confused. Supportive care is just any care that is supporting a patient at any time of their diagnosis and treatment. So palliative care and hospice care are all under supportive care. So whether a patient has disease or no evidence of disease, we know that supporting them through their diagnosis and treatment is beneficial. Palliative care, for the most part, even though you can provide that at the time of diagnosis, is generally an intervention or service that's provided to patients who have incurable but treatable cancer. So that is the difference versus hospice, which is a service that's also supportive, but it's offered to patients when they are at a point of their diagnosis where intervention is likely going to cause more toxicity and is unlikely to improve their overall survival. And that's care that's offered to patients when they're getting closer to the end of life and when we're talking about bereavement. So that's very different from what palliative care is. And I think this is the confusion that occurs with doctors, with patients, where there is a fear of having a conversation about palliative care. This is just another slide that really defines and separates what palliative care is from hospice. With palliative care, it's patients that are living with life-limiting illness, but their prognosis could be good, could be poor. It's really to maximize quality of life, maximizing support, whether it's community, familial support, symptom management, spiritual health care is a big thing, as well as psychosocial support. Very important when we're talking about hospice care. It's generally care that's offered to patients that have less than 6 months to live. So within weeks of months, with weeks or months to live, that's a very different kind of care. Sometimes ongoing medical treatments are given. Oftentimes, any intervention that is not going to improve or help the patient in terms of their symptoms is not offered when they're in hospice. It's really symptom management as well as spiritual and psychosocial. So it's similar to palliative care in that sense. The big difference is that with hospice, these are patients that are closer to the end of life. They generally have weeks or months to live, and generally medical treatment is not provided because it's not going to change the outcome. It's very different from hospice. And this is just a nice, I love graphs, I love pictures, I love cartoons, anything that makes, things appear simpler. So palliative care, like I mentioned, it's specialized medical care focusing on providing relief. I think it's important to know that it encompasses different groups of providers. It's care for life-threatening illnesses, but also focus on not just the patient, but as well as their families. You can provide this care at home, at health centers and hospitals. It improves quality of life. I will show some data evidence to show that it is beneficial. It also benefits health systems in terms of cost reduction, and it can be provided by many types of health professionals as well as volunteers. So the patient and the family are the focus of palliative care. Involves interdisciplinary group of providers, obviously physicians. Social workers are absolutely important in this setting. Therapists, pharmacists, nurses, spiritual counselors, particularly where you are in communities or cultures where spirituality is important. It's absolutely a must. It's imperative to include spiritual counselors and support in palliative care. I think for us as, scientists and medical folks and clinicians, there's always that, we talk a lot about evidence-based medicine, which absolutely is important. And sometimes we minimize the importance of spirituality, particularly to a lot of patients. So when we start talking about palliative care, it's no longer about what the physician thinks. Obviously, that's an important part of coming up with the plan, but a lot of the focus is on the patient and their family and what is important to them. The WHO has also put out statements because there's clear evidence showing that improving quality of life of patients and their families when they're dealing with life-threatening illnesses is absolutely important. So there's been the recommendation to provide this supportive care and palliative care very early on. We want to identify those who are suffering. We want to do that very early at the time of diagnosis. We want to assess those patients aggressively and treat pain and other physical symptoms or psychosocial symptoms, as well as spiritual needs. Palliative care can be provided when patients are actively receiving treatment. It's not one or the other. We provide the support while the patient's actively getting treatment. And the most important thing, like I mentioned, is matching the treatment options to the patient's goals. It's really about what the patient, their family, their loved ones think is important. The goals of palliative care are to, advance care planning, patient goals. I think when patients have been diagnosed with serious illnesses like cancer, a lot of power is taken away from this patient. You get a diagnosis, you're evaluated, assessed by, clinicians, and all of a sudden, those people take over your care and essentially take over what your life is going to look like for the next few months, years, or however long you have to deal with the disease. Palliative care is a way of giving patients some agency, some power. Once those conversations start happening, you get a sense of what the patient's goals are. So you're there to help them drive the car while they're telling you exactly what their priorities are. So really, the goal is advanced care planning. But obviously, minimizing suffering is a huge part of it, maintaining dignity and respect. And a lot of it is based on the needs of the patients, not necessarily on the prognosis. So it's not based on how long we think they're going to live, the number of weeks or months. That's more hospice. Palliative care is really just based on the needs of the patients at any given point during their diagnosis. It's appropriate at any age, at any stage in a serious illness. It focuses on the quality of the patient's life, not necessarily the quantity. And like I mentioned previously, we can initiate palliative care services at diagnosis, throughout treatment, as well as end of life, where you can then transition patients to hospice. And the importance of palliative care, I think, is very clear in the field of oncology. Even the NCCN guidelines and the American Society of Clinical Oncology have all updated clinical practice guidelines in terms of when palliative care should be initiated. They recommend inpatients and outpatients with advanced cancer. So anyone who's coming in with metastatic disease should receive dedicated palliative care services early in the disease course, concurrent with their active treatment. So it's become standard of care now. A patient comes in, it's very different from a patient who's got early stage disease, where a treatment plan is very clear from the get-go, whether there's going to be surgery, whether there's going to be radiation, chemotherapy, in terms of treatment. For patients that are metastatic, they're going to live with the disease indefinitely. So it becomes almost like a chronic illness. So these are the patients where palliative care interventions should be initiated at the get-go. Even if there are no identifiable needs at that time, there will be needs eventually. And so these, initiating this consult and the services early on and establishing this relationship so that the patients can then reach out when a spiritual need or physical need or financial need arise, set up, rather than chasing after it when the need, arises. And in terms of just, why we are such advocates for palliative care, and not just because it makes sense at integrating early palliative care into treatment plan in advanced cancer is actually associated with, improved, like we talked about, quality of life, mood, less aggressive end of life care. We know here in the US, we spend so much money at the very end of a patient's life that doesn't really benefit them or benefit the patient at all. So if we can, reduce the cost or necessary cost, I think that would be helpful to the patients. There is financial toxicity associated with a diagnosis of a serious illness. So we prescribe drugs, we recommend interventions, and patients, even though, most patients have insurance, it's not free. There's still co-pays. And so reducing costs to the patient is also something that palliative care is helpful and useful for. But it does decrease caregiver stress, and it improves overall survival when provided early. And you could see this Kaplan-Meier curves here showing survival analysis of patients who got early palliative care versus patients who got standard care. These were patients who had, in this case, this was a study in metastatic lung cancer patients, and you could see that overall survival was improved in patients who got early palliative care. Then the graph next to it was assessing quality of life, anxiety, and depression in patients who got standard care versus patient who got standard care and early palliative care, right? So they're still getting their, whether it's their chemotherapy or radiation or immunotherapy, but they were also getting palliative care intervention, whatever the needs were in that particular patient. So whether it was psychosocial, whether it was a mental health need, whether it was a financial need, whether it was coming up with advanced goals of care conversations, so the patient felt empowered. So those were things that were those were the interventions that were offered to those patients who got palliative care intervention, and it did lead to decreased quality, improved quality of life, decreased anxiety, and decreased depression in those patients. And this here is just showing, if you look at the bars, it's patients, once again, who had metastatic disease, who got spiritual support from the medical team, who got pastoral care services, and those who got both pastoral care services and spiritual support. And you could see very clearly in the blue that patients who had the spiritual, pastoral, and combined support had improved quality of life at near death, which is so important when patients are dealing with serious illnesses and really confronting their mortality. So we have the evidence to show that it works. It's not just that it sounds good in theory, but there is data that shows it works. Now, why don't we do this more as oncologists? I think, it's hard to talk to patients about end of life and their mortality and goals of care, right? Talking to a patient about their goals of care is the acknowledgement and, in a way, admission that it's unlikely that you will be here for a very long time. But some of the reasons that oncologists have come up with is that people don't want to know. It will make people depressed. It will take away their hope. Some patients will die sooner. It's not culturally appropriate. But the facts actually is that most patients do want this information. And there's data showing that depression and anxiety are no more common. I mean, people who are aware of their disease, that hospice and palliative care are associated with longer survival. So patients will not die sooner by having that information. If they want to have that information, we can we can be honest and still be hopeful at the same time. And it's always culturally appropriate to ask. I think, when we're having sensitive conversations, the most important thing to start off with is asking the patient, how much do you want to know about your illness? And I've been pleasantly surprised. Most people want to know, even people that I thought didn't want to know. There are some patients, they are a minority, who will say they don't want to know, don't talk to me about it, whatever happens, happens, or talk to my daughter, talk to my husband, I don't want to know, and then we respect their wishes. But I think it's important to always ask, how much do you want to know about your illness? For many people, knowing and making decisions and setting up their future, if they have young children or family members that they feel responsible for, is a way of giving them that power to make decisions. But in terms of feeling hopeful, there was a study that looked at patients who got, information about their disease and their prognosis, and you could see really no difference in how hopeful people felt, including patients who had poor prognosis. I think it's important for us to develop the skills to have this basic conversation, such as, asking patients, what is your understanding of your situation? How do you like to get medical information? What is important to you? What are you hoping for? Just, having conversations about prognosis, goals of treatment, what suffering means to them. It's different for everyone. And I think doing that allows patients to feel like they're part of the conversation. You're a team with them. You're not doing things to them. You're doing things together for them. And that really changes the energy, changes the dynamics, it changes the trust that a patient has in their physician. And having that trust in their physician does help a patient, does help that patient in terms of their quality of life. I think trusting your physician and feeling confident in decisions that are being made about your health, I think improves your general understanding and feelings about how you think you're going to do. So these are the kind of open-ended questions that I think creates bonding between doctors and their patients, and you get to know them, what they want, and you can then advocate for your patient as well. And this is just showing the reduction in cost. So if we want to sort of even just talk about the bottom line and talk about finances, which at the end of the day, that's always an important thing, that you actually see that post-palliative care cost, really for patients who got usual care versus palliative care, that the cost of the medical care actually was decreased in patients who got palliative care. And these were in patients, older adults with advanced cancer. This was a study that was published in the American Journal of Hospital Palliative Care in 2021. And this, I think, was the study that really, I think anytime you're talking about, oh, if there's this intervention in general, it actually saves, money, I think people start listening. And I think over the last 3-4 years, palliative care and the importance of palliative care has become, more mainstream, even though, palliative care physicians, which I'm not, we do have palliative care doctors, but we work very closely with them. And this is something that I'm passionate about. So I'm also, I'm also there advocating for patients and then referring to palliative care physicians if there are things that I think they may be better at handling than I am as a medical oncologist. But this study showing the cost savings associated with palliative care, I think has just led to everyone now wanting palliative care involved in caring for all their patients, which it's a good problem to have because the patients do benefit from it. So in terms of eligibility and who's appropriate for palliative care, I mean, we're talking about oncology, at least that's what I'm talking about. So the population that I focus on are patients with advanced cancer, patients with a lot of symptom burden from their disease, but there are a slew of patients who can benefit from palliative care, not just patients with cancer, patients who've got chronic pulmonary disorders, your patients with, chronic obstructive pulmonary disease, your COPD patients, your patients with pulmonary hypertension and pulmonary fibrosis. These are patients with chronic illnesses that affect their quality of life in such a negative way that anything to support them is absolutely important. Your patients with advanced renal disease who may be now requiring dialysis, your patients with congestive heart failure, patients with end-stage AIDS, liver disease cirrhosis, patients who are no longer candidates for liver transplant, patients with neurologic disorders, your post-stroke patients, your patients with dementia, patients with neuromuscular disease, and patients coming in with multi-organ system failure definitely benefit from supportive care. I think sometimes we forget that, patients who, lack the financial means to care for themselves, sometimes you write these prescriptions for patients and you're like, oh, they come back and they haven't taken their medicine. And there's this frustration that there's something you can do, but the patient is not compliant, as we call it. Sometimes it just requires having, a social worker talk to the patient to get to the bottom of why they're not picking up their medicine. And then you find out, well, they actually cannot afford the medicine. And if you're in an environment where there is, some sort of safety net or support that the patients can get, that may be all that they need. And so these are the kind of patients that are, eligible and appropriate for palliative care. And then when there's a conflict in the goals of care, you as a physician may think, being slightly more aggressive is beneficial to the patient or maybe not, and the patient is agreeable, but then there's a family member who doesn't think so, even though the patient is your primary priority. There are all these people surrounding them that are trying to make decisions on behalf of a patient who still has capacity. Sometimes getting them into, palliative care services where there is a social worker, there is a mental health expert, there is a spiritual counselor to kind of really tease out what the problem is so that you and the patient can make better decisions for the patient and not necessarily for the patient's family, even though they're all part of the team. So anytime there's conflict in managing a patient, getting palliative care involved is usually very helpful because then they can really dive really deep to get to the bottom of things and really help solve some of those problems for us. So in terms of when you should consider palliative care consult, I already kind of spoke about that on the previous slide, but I think in addition to all of that, when you do have a care team, which could be the doctors, the nurses, the pharmacist, those that are primarily responsible for the patient's medical care, anytime that team and the patient or the family, anytime there's a need for complex decision making and determining goals of care, I think having palliative care consult is important. Sometimes when there's uncertainty about end of life, uncertainty about appropriateness of the therapy options, sometimes patients come and they want everything, and that whatever intervention they're requesting is unlikely to benefit them. It's likely going to be more toxic, and you're having a difficult time communicating that to the patient as a physician. Some of us are very well equipped to do that. Some of us aren't. When you're not, that's when you want to get a palliative care consultation in there. Anytime you have divergent views over care, which is essentially the same thing, there is conflict, it's important to get palliative care as a third party. I think part of having palliative care involved also from the very beginning, even when there are no active needs, is that when you get to this point of divergent views or conflicts, you already have a palliative care team that knows the patient, that has been present from the very beginning, and they're not just showing up as strangers when things are not going in the direction that you think it should go as the primary care physician or oncologist, whatever specialty for that patient. I find that having palliative care involved from the beginning, even whether it's just to introduce the patient to them so they know they know of each other, really helps when things get difficult, because you're not now bringing in a stranger into this conversation. The patient is already aware of what the palliative care team, what they do and why they're present. And it's absolutely important to have palliative care involved when there's metastatic cancer with no response to treatment, and you are now at a point where you need to start having some difficult conversations. I think traditionally that's how we were using palliative care. I think more and more we're getting them involved from the very beginning, so that when you get to this, multiple regimens of treatment are no longer active, they're very quickly in the mix to help us take care of this patient and make some difficult decisions for the patients. So moving on to some of the symptoms in advanced care that I'm not going to talk about all of them, but there are a couple that I think are important for us to be comfortable in managing. Right. So patients with advanced cancers will come in with asthenia, anorexia, lack of appetite. They sometimes lose a lot of weight. Pain is so debilitating for many of our patients with advanced cancer and grossly undermanaged. So I will talk a little bit about that. Nausea, constipation, sedation from pain medicine sometimes, and then the dyspnea that sometimes patients experience from pulmonary disease. But I think pain is something that we could do a better job of managing. And I'm going to talk a little bit about pain when I talk about some of our interventions. So palliative interventions, when patients are metastatic, chemotherapy is a palliative intervention in someone who's got metastatic disease. So they are not curable. You have stage 4 breast cancer, you have stage 4 colon cancer. So this is not a disease that's going to go away completely, because this is now widely metastatic, but it's treatable. And what you're doing by treating is to reduce tumor burden. And by reducing tumor burden, the patient's vital organs are able to function and the patient's able to be active. Many patients are on chemo, they go to work. They're still functioning members of society. So it is a palliative intervention. I think sometimes when people think of chemotherapy, they think of it as being, oh, this is very aggressive treatment. And sometimes it is, and many times it's not, particularly when patients are metastatic. The goal of treatment at that point is finding a treatment that the patient can tolerate, but that's also going to control disease. I have patients who've been on chemotherapy for 5 or 6 years. Every 3 weeks, they're getting their treatment, and somehow they still have stable disease or no active disease. So it's a palliative intervention, right? So the chemotherapy, the antibodies, the endocrine therapy, it's not always chemotherapy. There are many non-chemotherapy drugs in breast cancer and in prostate cancer. We use endocrine therapy. We use antibodies in some other types of cancers. So chemotherapy is not just one thing. Systemic therapy is medicine that we give patients that goes into the bloodstream and systemically. Chemotherapy happens to be one of them, but there are many non-cytotoxic treatments that we give patients who are metastatic and is considered a palliative intervention. Sometimes radiation will be palliative. Someone's got a lesion in their hip, and even though it's metastatic, but it's very painful, we'll radiate that lesion for pain control. Sometimes some surgical interventions are palliative, because anything that is any intervention in a patient who's widely metastatic to improve symptom, to control pain, to improve quality of life is considered a palliative intervention. Now, if you move to the other side of the screen and you look at the potential palliative care interventions, we've talked about emotional, spiritual, psychosocial support. We're talking more about now controlling pain, shortness of breath, nausea, vomiting. And then you see some of the interventions that are generally not palliative. When we start talking about doing CPR in those patients that are, that have a lot of disease burden, putting them on ventilators, just highly burdensome interventions are generally not palliative. So these are interventions that we try not to engage in when patients are presenting with metastatic disease, particularly if it's active disease where the disease is not very well controlled. You really don't want patients getting aggressive measures or interventions for disease that you're not going to be able to control. Then they have those variable interventions. I love that, transfusions is one of them, since, a lot of the conversation this week is going to be on blood transfusions. And I think for us in the US, because we have access to blood transfusions, we have access to a lot of things that may not be available, maybe other, maybe middle or lower income countries. We just throw everything in, but we're seeing that these really should be variable interventions because transfusions are not always beneficial. I'm sure there are going to be others talking a lot more about the pros and the cons, but I think it's important for us to really sit there and think, is this actually helping? Is this actually palliative in this setting? And so these are the questions that, any palliative care physician and any oncologist with the palliative care mind, knowing that that's important to their patient's outcome, will spend time thinking anytime you have to make this decision. So I just want to talk a little bit about pain, because pain is a huge part of what patients with advanced cancer deal with. And it's something that oftentimes is undertreated. And there are many people who feel very strongly about controlling pain. Dr. Catherine Lee Gailey-Camus, who was the WHO's Assistant General, Director General, mentioned, I love her definition and her assessment of what relief of pain is and why it's a right. And she says physical, emotional, spiritual, and social control is a human right in terms of the relief of pain, because the relief of pain allows patients to exist in all their physicality, emotional space, spirituality, and their ability to be social. And this she considers a human right, which I agree with, that everyone has a right to be treated and to live or die with dignity. And that's impossible to do when there is significant pain. Palliative care is one aspect, and controlling pain is a huge part of what palliative care does, besides all the other things that we've mentioned earlier. So palliative care is an urgent need for people living with advanced stages of cancer, particularly in developing countries, because there's a high proportion of people with cancer. They're being diagnosed when treatment is no longer effective. Many patients are coming in with higher stage disease. So the importance of palliative care, the importance of pain management is something that should be recognized in those settings. It's been estimated that about 5 million people suffering from moderate to severe pain caused by cancer do not receive treatment. So if many patients in these communities are getting diagnosed with high stage disease, and we know that many of them are coming in with pain, that means there are way too many people that are living with pain with their disease, and we need to do better than that. The WHO projects that cancer deaths will continue to rise, with an estimated 11.4 million dying by 2030. 80% of those patients are going to be in low and middle income countries. And 60% of people living with cancer live in these countries, and they have minimal access to pain and symptom management, which means far too many people are living with intense suffering and pain. And when you actually look at the use of narcotics, at least morphine, when you look at the morphine equivalents, you can see on this graph the amount that's being used in the US compared to Japan, compared to Nigeria, which is almost like non-existent when you look at the morphine equivalents, that we all need to do better, all of us, in managing pain in our patients that have been diagnosed with advanced cancer and just other types of diseases that are associated with a lot of pain. The inability to control pain basically negates whatever it is that you're doing to control a patient's disease. If pain is active and not controlled, giving them chemotherapy and whatever intervention to manage their disease is not doing much for their quality of life and their desire to want to live and live with dignity. So we need to make sure that in addition to all the palliative care interventions that we've talked about, that pain control is also considered an important aspect of managing this patients. And this is just a slide showing basically what I mentioned previously in terms of opioid consumption. It's an opioid consumption map. And when you look at it, you know, the blue is North America, and then you could see Australia and then parts of Europe. But when you look at other parts, blue are, you know, are countries that have lots of morphine use and access to morphine. And then when you look at other parts of the world, you know, the numbers start going down. And then the countries in white don't even have any data. And so not sure, you know, how patients are being managed in some of those countries. But we need to get the word out, and we need to do better in managing pain. Pain is now considered, you know, the fifth vital sign. You know, it's you're getting their blood pressure, you're getting their heart rate, you're getting their respiratory rate, their oxygen saturation. Asking about pain is now considered a fifth vital sign, and I think we don't do a good enough job of documenting and asking people about their pain. So, well, what can we do to relieve pain? We know that 30% of patients with newly diagnosed cancer will present with pain. About 70% of those patients are receiving active therapy, and up to 80% are in advanced disease. So how can we manage something that exists in so many of our patients? And, you know, the WHO again has demonstrated that most patients and most of cancer pain can actually be relieved if we implement an available pharmacologic approach. It's very inexpensive. It's practical. It's one that I use, and it's something that can be used worldwide, where we use this 3-step ladder to categorize, you know, pain level. 1 is mild, 2 is moderate, 3 is severe. Someone's coming in with mild pain. It's very easy to manage, whether it's with, you know, acetaminophen, Tylenol, your non-steroidals, anti-inflammatory agents, the ibuprofen, aspirin. The pain is moderate. Then you start adding, you know, slightly more active pain medications, the codeines, the hydrocodone, oxycodone, tramadol. If it's severe pain, then you escalate to more of the morphine, hydromorphone, methadone. And we talk very passionately about the need to manage pain control, but we are also aware of the addictive potential of some of the opioids that we do use. So it's absolutely important to assess patients, assess their pain, and escalate as needed. Most patients won't even need to get up to the severe level of having to be on a narcotic that they can get addicted to if the pain is addressed when it's still at a mild level. Oftentimes, we don't do that. Oftentimes, patients also don't verbalize their pain, and oftentimes they'll verbalize the pain when it's now extreme, and you have to prescribe the bigger, more intense narcotics. But in terms of the steps, you start with step one, it's mild pain. You use, like I said, the non-opioid drugs such as acetaminophen and the non-steroidals. If the pain is persistent, you escalate to the second step, which is with the weak opioids. And you can use this weak opioids in addition to the non-opioid agents. I oftentimes will give hydrocodone and ibuprofen together and tell patients to alternate. Non-steroidals are highly underrated. They really work well for pain control. So mixing that and alternating sometimes is all a patient needs, that you never have to escalate to the step 3. But sometimes patients are presenting that way, or your combination is not helping, then you move to the strong opioids, which would be your morphine and the hydromorphones and all of that, which you can use for a short period of time. But in patients who are metastatic, who are in chronic and constant pain, who their overall prognosis is poor and maybe have just a few months to live based on your experience and knowledge of their disease, I think addiction really is not an issue and is not a concern for palliative care physicians and palliative care providers when you're dealing with patients at that level. Because some of the counter argument is, oh, well, we're worried about our patients becoming addicts. It's like, well, if the patient's end of life is, 3 to 6 months from now, that is not priority, right? And these are not, the patients that you're worried about, addiction potential are often not the patients that require a lot of, of narcotics. Your early stage patients are treated completely differently. This model is for your patients with advanced cancer. They're coming in with bone lesions, everything hurts. They're coming in with disease burden in the liver, in the lungs. They've got ascites, just all of that. They can't sleep because they're in pain. I think talking and being concerned about addiction becomes less of a priority in that setting, but I think it's an important conversation to have. It's important for patients to know the strength of the kind of medication they're on, and the pros and the cons of the medications they're on, and the importance of being responsible while using these drugs. This is a table that shows, I mentioned pain, obviously, anorexia is a big thing. Patients do come in and they are worried that they're losing weight on a daily basis. They're starting to look cachectic. They're embarrassed to go out because they don't like how they look physically. They look very different from how they looked before their diagnosis. This table is very helpful. It shows the doses and the uses of appetite stimulants in patients who've developed cancer-related cachexia. Sometimes just using steroids, just prednisone, dexamethasone, methylprednisone is all that you need to help a patient actually improve their appetite. We use Megase a lot, which is, it's a progesterone analog. It can increase the risk of blood clots. So I am very careful, and it's not my favorite to use, but sometimes we'll use it. Then you have some data for cannabinoids, the THC derivatives, the medical cannabis. There's still a lot of research that's happening in that space, but the THC, there's a prescription drug, it's called Marinol, that we do use twice a day, and that is something that is approved. We write by prescription. They don't need to go to a dispensary to get that. But in terms of how medical marijuana actually works, I think that's still debatable, and that's not something that is mainstream right now. And then some of the serotonin antagonists, like olanzapine, have been shown to stimulate appetite in patients with chronic diseases. So these are some of the interventions that, as we're giving chemo to the appropriate patient, managing pain, that we're also supporting patients in their appetite, because the anorexia is always of big concern to patients. So I will end my talk with my summary being that palliative care is important and it's beneficial to all. I know it says breast cancer patients, but to all cancer patients, multidisciplinary teams, nutritionists, psychologists, pain management, palliative care specialists are important, really important in advocating and implementing palliative care services. Early introduction of palliative care is important in patients with cancer. We have data showing that it improves quality of life and likely improves survival. And I think, just as a reminder, which I think it's what this symposium is about, is, really to remember first to do no harm. So that is the end of my talk. And thank you for being here with me.
Thank you very much, Dr. Tayo, for this great, very clear, informative presentation showing the great place for palliative care in oncology, the goals of care. As you were presenting this, I was really, in my case, I was reflecting on my patients I've been looking after. I'm still looking after with cancer and how much one needs to care for them, really. Thank you very much. It's a real great presentation. I'll call upon my co-moderator to handle the question and answer session. Becky?
Wonderful. Thank you very much. So as we will begin the Q&A section now, just as a reminder to everyone that Cassandra Upchurch, who was going to be our third presenter for today, her talk has been moved to Friday. So please tune in on Friday to see Cassandra's talk about complementing palliative care with nursing. So to open up the Q&A, please remember, everyone, you can enter your questions into the Q&A chat section. And here's where we will pull on some of these questions for you. I want to start with Dr. Bloomberg. There was a question in the chat that you have answered a good part of it, question from DeWitt, and it was 3 parts. So I'm going to ask you to comment on those again. The part of the questions were about any numerical data that was related to transfusion-related infection and mortality rate, and the pathophysiology behind cancer in transfused cancer patients. But I wonder if you could also comment on that medical, ethical, and legal aspect of, now that we know that ABO incompatible platelets can be associated with so many harms, what the implications are for clinicians who continue to use that process, that treatment in patients with cancer.
I'll start with the ABO question. This is very complicated because you have professional organizations like the American Society of Hematology, based on really bad data or no data, that ABO doesn't matter for platelet transfusion. So it really isn't clinicians at the bedside who are making this decision. It's the blood transfusion service saying platelets are hard to inventory because they can be stored for a short time. So we don't want to see them outdate. So we'll just give whatever blood group. The problem with this is they probably don't work. They're not efficacious. They don't provide prophylaxis or treatment of against bleeding. And they make it less likely that future transfusions will work appropriately. And they probably increase bleeding instead of decrease bleeding. It's the worst possible situation. It's like we decided we're not going to wash our hands before delivering babies because there's no evidence that washing our hands works. And that's what the situation was in 1840. And for the next 20 or 30 years, till Joseph Lister invented the concept of aseptical surgical for preparation and treatment of the patient, this was the standard of practice. So this is the standard of practice throughout the world. In fact, in the United Kingdom, The recommended platelet, if you don't have an ABO platelet that's matched, is to give group A platelets. This is the worst possible treatment we now know based on the last few years of data. I could just say medically, legally, it's obviously a setup down the road for patients who might have been harmed if they find out about it to, in fact, yes, say, yeah, it was known, certainly in 2023, 2024, that this was a really bad idea. And the defense will be, this is what we were given. This is the standard of practice. But the standard of practice in this case is terrible and wrong. Scientific data are quite clear on this. Unfortunately, there are a couple of papers in the literature that purported to show that ABO doesn't matter. The problem with these studies, they were methodologically hopeless. They characterized patients by their first transfusion. Was it ABO identical or ABO non-identical? And it didn't matter whether you got 50 non-identical transfusions afterwards, you were still in the ABO identical group. Now, this is total rubbish. But they passed peer review, and I was actually a reviewer of one of these papers and pointed out the problem. But these are papers that are constantly quoted by people who say, oh, ABO doesn't matter. But the data suck. They're just hopelessly scientifically. People, I don't know why people did these studies this way. They didn't report. There are ways of methodologically looking at this. If you have a cancer trial and you have protocol violations, you report, well, how many patients got the wrong treatment? In these studies, they didn't report how many patients in the ABO identical group got ABO non-identical platelets and how many platelets. It's just bad science, but it's in the literature in prestigious journals. It's really hard to know. I mean, there are many cases in medical history when old ideas were proven to be wrong. If you're a surgeon and you do breast cancer surgery, you know the story of lumpectomy versus radical mastectomy. There are equivalent things as well. I know it sounds like a rant, but it is one of those bizarre situations where totally incorrect and harmful information is being cited when there are randomized trials showing the contrary. So medical legally, it's a morass, and who knows how it'll play out. It wasn't in 2000. I mean, we did some of the original work on this, but in 1994, I think we published it. And it wasn't until 2005 that we realized this affected surgical patients, not just patients with hematologic malignancies who get many, many platelet transfusions. And so we converted to trying to not infuse ABO mismatched antigen or antibody. But we're the only hospital in the galaxy that's doing this. It's a strange story.
Yeah, absolutely. That's such a dilemma with, you talk about the incidence of bad literature, bad research out there. And then we also have that lag time between when new evidence comes out and when clinicians pick it up and incorporate it into practice. So we have the struggle of getting the new and the better information being recognized and adopted, but this bad research continuing to perpetuate the bad practice. Yeah, that's definitely challenging. I wonder if you could also answer that, talk about your response to that second question. One of our attendees asked about whether you were suggesting the increased incidences of cancer after transfusion are due to infusion of cancer cells or an immune response leading to incidences of cancer. Can you comment on what you responded to there?
Well, I'll amplify on it and just say that we haven't the slightest idea. But we can wave our hands and speculate that based on what we know, it seems unlikely that it's infusion of cancer cells. We're collecting blood from healthy donors. Very few of them have probably covert cancers. So I think that's unlikely. We know that transfusions dramatically affect T cell and natural killer cell function, which are important in what we call tumor surveillance, because there's no question that cancers occur at a finite rate in otherwise healthy patients and never develop. This seems likely. So the immune hypothesis would seem to be speculatively the most likely. The other possibility is that there are tumorigenic viruses that we don't know about that exist in nature. Very few human tumors seem to be virally related, but it's possible. It's unlikely. So I think of the three major possibilities, and this is pure speculation on my part based on what I know at this point, because there are really no data to tell us which is correct, that the long-term immune effects of transfusion may be responsible, in part.
Oh, interesting.
But it's
Thank
an
you.
educated guess, not based on any scientific hard data.
Okay, fair enough. So just so everyone knows, we do have some additional panelists who've joined us who, in addition to our speakers, if any of our panelists would like to jump in and provide any comment or response to a question, by all means, we'd ask you to raise your hand or jump in as you would like. So for the next question, I would direct this one to Dr. Taiwo. One of our attendees is asking if you maybe feel that the staffing concerns within the United States, such as shortages and the turnover, particularly what we've seen over the last few years, if they might be contributing to timely and appropriate palliative care, treatment and arrangement of this. And if that is a factor, how are we helping to manage this to support patients?
I mean, that's a great question. And I think the reality is that we are short-staffed everywhere. COVID did a number on the medical system, and we're still recovering from that. So yeah, I do believe like staffing issues, high turnover is really, reducing the access to some of this palliative care support referrals and interventions. So I think how we can help these patients is, as physicians, becoming comfortable in providing palliative care interventions. First, having difficult conversations, knowing when and how to manage pain, knowing when and to have your social worker involved. Social workers are amazing. They do so much. Knowing when to have your chaplain, if there's one in the cancer center, I'm involved in helping your patients. So many cancer centers do not have palliative care as a service per se. The bigger tertiary centers do. Thankfully, I work at an institution where we do. So I think first is us knowing the importance and plugging this patients in very early. So yeah, have your social worker on board, know how to manage, anorexia, dyspnea, pain control, and then, listen to the patients. I think that's helpful. So I think that's how we can help the patients.
Okay, thank you. Another question proposed by DeWitt is with regards to palliative care. So if pain is low grade, such as level 1, which might be considered mild, but it's sustaining, so it's ongoing for a long time, can you comment on the appropriateness of starting those more higher grade, higher risk pain medications at that time? Is that reasonable? How would you approach that?
I mean, that's a consideration. I think what I've started doing, I mean, there's so much we're learning and medicine is changing, and I think we're becoming more open to alternative ways of managing pain. There's good data showing the benefit of things like acupuncture. So at Cornell, we have an integrative medicine center. So patients are referred, they will get acupuncture. They have things like meditation. They have things like yoga. And it all sounds very kind of non-medical, but there's data more and more that's showing that some of these interventions are helpful. So I actually, a patient like that in the setting that I'm in, I would refer them to complementary medicine, integrative medicine service. And I'm very, very supportive of my patients getting acupuncture because there's data, and I've also seen it be very active and effective in my patients. And for those who, I live in New York, there are lots of acupuncture centers. I tell patients, just go get acupuncture if you can pay out of pocket for it. Some have insurances that actually will cover and reimburse patients for things like acupuncture. So yes, acupuncture, massages, acupressure, meditation, yoga in breast cancer patients have been shown to be very helpful in terms of pain control. So I will consider that first before moving on to the second tier level of pain medicine. But I know that's not available everywhere. So I think if a patient is uncomfortable, you have to manage their pain. And if you have to move it on to the next grade, I will alternate level 1 and level 2. That's how I tell my patients that every 6 to every 8 hours, take an ibuprofen, then take the oxycodone rather than just oxycodone. Yeah.
Mm-hmm. Yeah, thank you very much for that. I know that some institutions who have been able to develop acute and chronic pain programs that cross over surgery and oncology care have really been able to bring that option of alternative practices into improving care in the latest research. So another question that fits alongside that with looking at different options and alternatives is asking about the role of food as medicine in updating medical care. And they use a specific example about copaiba oil. I'm not sure, I'm not familiar with that, but that is an option to bring comfort and improvement in patients' comfort and improvement of appetite. So I'm not sure if you're familiar with that specifically, but if you can comment on nutrition, so the role of food in medicine.
Yeah, that's also another important thing. I don't know what copaiba oil is. It's not something I've used or I've heard of, but we do know food is food as medicine is something that also has been studied when they've looked at patients who consumed what we call a prudent diet, so which is more plant-based. They're less inflammatory. I think we're all very busy. We all move very fast. A lot of what we eat is processed. But in terms of healing the body, reducing inflammation in the body, also as a cancer risk reduction intervention, eating more plant-based foods definitely do improve patients' general health and acts as medicine for eating things that are from the ground, right? So a lot of us have moved away from that. It's actually, for me, a bit distressing that some of our not so great behaviors in the West in terms of how we eat has also been imported to countries that actually could eat much better and teach us how to eat. So so food as medicine is another thing that I'm very passionate about. And yes, there's good data for that. I do not know about copaiba oil. So those are conversations that I actually do have with my patients about, when when they've been diagnosed, they're on chemotherapy, or we have nutritionists and people who have those conversations with patients, but patients want to be a bit more active in their care. What do I eat? Do I eliminate this? Do I eliminate sugar? And it's like, no, there's sugar in fruit, and there's sugar in plants. It's not eliminating sugar. It's more about the processed foods that we eat and the spikes that happen in our body, the sugar spikes when you eat, something that's processed. The insulin's up and down, up and down. What you want is steady state. And those plant-based diets keep you at steady state and reduces inflammation in the body.
Oh, that's very interesting. Thank you very much for that. Sure. Okay. I've got another question that I would like to pitch at both you, Dr. Taiwo, and Dr. Bloomberg. So with your talk, Dr. Taiwo, about many of the interventions involved in palliative care, looking to improve a person's quality of life and their health, so we can perhaps extend things somewhat in a comfortable way. But there we have that dilemma of transfusion use, where some clinicians, unfortunately look at it, well, when I give it, my patients feel better. But at the same time, we've just heard this evidence that talks about how this may actually not prolong life and cause a lot of harms. So I wonder if both of you can comment on how do we have those questions with both patients and with other providers, and perhaps We talked about the source of perhaps some of the really problematic ones, ABO incompatible platelets coming from the blood bank. How do we have these conversations with patients and providers about the best approach that can be used in palliative care when it comes to transfusions, or use or not?
I'll let Dr. Bloomberg start.
Well, actually, I was going to say the same to you, since you're actually a treating bedside practitioner, whereas I'm not.
Mhm.
The subject of end-of-life transfusions is a complex one, for which we have very little data. And in talking to my colleagues who practice, at the bedside, there is a big problem in that, in the United States at least, most hospices and palliative care facilities do not transfuse patients. So it's not an option, and that's a problem. And the reason it's a problem is because we know empirically and experientially that there are some patients who report enormous improvements in their physical well-being, fatigue, ability to carry out the activities of daily life, et cetera, just a general sense of how they feel after a transfusion. And it's important to realize that, one, this isn't universal. It's not based on widespread evidence. Studies that have looked at this find that some patients feel worse, some there's no change, and some feel better. And you don't know until obviously you try. And there are other therapies that are ongoing that may have an impact on this. So I think we just have to accept that we don't know, and that if you've tried everything else and the patient is still feeling terrible, in an end-of-life situation, then transfusion is something that might be reasonable to try, and then go from there. You might say, well, you have the risk of infection, hospitalization, thrombosis. Well, these are patients, as Dr. Tawu discussed, in the last few months of life, and maybe it's better to die of a sudden pulmonary embolus than live in chronic misery for 3 months. This is a personal decision. And I don't have the answers. I can just posing some of the questions, and I'm sure you have personal experiences that you can relate, Evelyn.
Yeah, I don't have the answers either. I think, there's, patients are different. I think a patient who's in hospice, because generally when you're in hospice, blood work is not being done. So those patients are generally not going to get transfusions. Patients that are getting treatment and are also receiving palliative care services, if they're getting chemotherapy, they will, you have parameters for what their numbers need to be for them to get certain treatments, right? Your hemoglobin needs to be 8 grams or whatever. So you have no choice but to transfuse those patients because you cannot treat them. You actually have cutoffs. Your platelets are less than, 100. We're not going to give you chemo. It's very easy with platelets. We just wait for platelet recovery. We're not going to transfuse someone whose platelets are 100,000. But for a hemoglobin of 6.5 or 7, who's gonna get chemotherapy, you'll probably give the blood. But it's on a case-by-case basis, very similar to, your patients with sickle cell disease, where if someone's baseline is 6 and they're fine and functional, you're not going to transfuse them to get them above 6 because they're fine. So if a patient has a pattern of they feel really terrible, and then when you give them blood, they feel much better, yes, then you do it. For a patient who there's no difference in how they feel post-transfusion, they've declared themselves as someone who is unlikely to benefit from blood transfusion. So I think our job as oncologists, as physicians, as nurses, really is just to understand that transfusion is not the answer to everything, but it doesn't mean don't transfuse. You just transfuse the right person if you think it's going to help. Yeah.
Thank you. Thank you for that. One more question that Dr. Bloomberg has answered in the chat, but I wonder if you could elaborate on that with the group. Was the question about, would platelet antibody tests be more beneficial if they were done earlier or prior to, when a patient may seem like they were perhaps unresponsive to platelet transfusions?
Right.
Can you share your answer there?
So what we're talking about here is something called platelet refractoriness. Unfortunately, it doesn't develop in the vast majority of patients with cancer because they're not getting lots of platelet transfusions. The exceptions are primarily the acute leukemias, particularly in adults, and perhaps stem cell transplant patients who may often get multiple platelet transfusions. And the patients who are at greatest risk of becoming refractory are those who have had multiple exposures to other patients, to other people's HLA antigens, because refractoriness is almost exclusively caused by what we call anti-human leukocyte antigen antibodies, usually class 1 A, B antigens. And of the population most at risk are women who've had multiple pregnancies, for example, and thus been exposed to paternal antigens. And there's a lot of misinformation in the literature about this. We do know from randomized trials that transfusions that aren't leukoreduced, that haven't had most of the white cells, donor white cells removed, are very prone to cause refractoriness. In fact, when I was in training, about 50% of the patients with acute leukemia who survived for much shorter periods of time back then, about 50% of them became refractory. Once leukoreduction became common and used in hematologic malignancies, it went down to about 20%. So that's still not great. 1 in 5 patients becoming refractory, and that makes, as Dr. Tawu mentioned, difficult to deliver the hopefully curative chemotherapy, because if the platelet count's sufficiently low, you're maybe reluctant to give additional doses of drugs that are myelotoxic. The good news in the short story, which almost nobody believes, despite the fact that there are 2 randomized trials, one in the British Journal of Hematology and one of the Annals of Hematology 30 years ago. And then we wrote a research letter in the New England Journal of Medicine a couple of years ago saying that if you give ABO-identical transfusions and leukoreduced transfusions, the refractoriness rate is essentially 0. 0 is a good number. Nothing's 100% or 0% in medicine, but this is pretty close. But this is most blood transfusion services kind of throw up their hands and say, "Oh, we can't do that. We can't do that." And of course, that's not an excuse. You make an effort, and maybe you start with acute myelogenous leukemia patients or some other very high-risk group and say, "We're going to give only ABO identical to that group." The question here specifically is, would it help to do antibody studies before refractoriness? And the answer is no, because you don't need, it's not going to help you. And it's not going to tell you what to do. And so I don't see a role for that. And since this is something that, like infectious diseases like smallpox or measles, we don't have ways of treating them once you get them. And refractoriness, we do have ways of treating it, giving HLA matched platelets, giving cross-matched platelets, and these usually have some benefit. But the best thing is to prevent it in the first place. And it has the advantage that once you, if you don't have refractoriness, you don't have patients using huge numbers of platelets. So this is a win-win-win type situation. Get your blood bank to give you only ABO identical platelets if your patients need platelets for repetitive transfusions. Mostly it would be the acute leukemias.
Terrific. Thank you very much for that. I do have a question from, I think it's Marilia, who is asking a few questions. One of them, the last one, I think is quite interesting because I don't know whether there is any clear response to it in many places. But first of all, they're asking about your approach to discuss allogeneic transfusion with patients, how you present the risks, everything from common and maybe the milder risk through the risk of death that patients might experience. She also asks about follow-up post-transfusion. And then this is the one that I'm quite interested in, whether any countries have specific laws with regards to blood transfusion. My understanding is that most of the time, this is governed by health institutions, and there aren't any type of laws involved. But I wonder if either of you, our speakers, or if anyone on the panel can comment on all of those questions that Marilia asks.
So can you break it down? Which one do you want to answer first? Let me see if I have the, because they all sound very blood bank related and lab medicine related.
Well, I
I
can
think-
start if you want, and just say that most informed consents do not include a lot of the risks I discussed, because transfusion medicine folks and a lot of practicing physicians at the bedside are in denial about the data. The data are pretty clear, but they're not included. But there are enough risks discussed in the informed consents, and Dr. Taiwu probably can comment, because she although I suspect it's mostly her nursing staff that do the informed consents for transfusion in many cases, maybe not at Cornell, but certainly in our institution, the physicians are not the ones doing the consenting. And they do not include they do mention the possibility of death due to other causes, because there are plenty of other things that can kill you from transfusion. And the answer to the second part of the question is, I don't think we follow up recipients who get allogeneic transfusions at all. Basically, if there's a problem, you come and see your physician. May not be related to the transfusion, of course. And as far as the laws are concerned, in many states in the United States, informed consent's required. But I think most patients, with serious disease is confronted with a 6-page or 15-page informed consent. Just sign that. I know that's what I do. I'm not about to read. I'm not sure informed consent, as we currently practice it in the United States, which is a very bureaucratic thing, helps patients very much. But I'll leave it to Evelyn to discuss these issues.
No, absolutely. I don't know that there's even much to add, because transfusion happens on a pretty regular basis. I think we've sort of normalized it. We are aware of the significant risks that are associated with it, but I think we don't think about it often enough, because if you did, I think a lot more people would probably not want to get blood transfusions. So you talk about, the infections and all of that. It's like, oh, but the blood gets, it gets checked, and, viruses have been, eliminated. No one's getting transfused blood that has viruses and all of that. And I think from a cancer standpoint, the patients we're also seeing are they're very sick. They're getting toxic treatments oftentimes. And what they're getting is oftentimes more toxic than the potential risk of any additional intervention. Patients are just trying to stay alive. So I don't know that, even if they knew the real significant risks, that they would refuse transfusions. I think it's really us as physicians being more aware and being very mindful of when we do order blood transfusion. Is it really necessary? I know for, there's data for using erythropoietin stimulating agents. We do that in our metastatic patients. We don't do that for patients with early stage cancer, because there's data that it can actually lead to tumor progression. So we don't do, the Procrit and the darbepoetin in non-metastatic patients. In the metastatic patients who are on treatment for a long time, we definitely do consider the erythropoietin stimulating agents as a way to avoid transfusion as well. So, so transfusions become very routine. I think we've forgotten or don't think much about how serious of an intervention it is. And I think just what's happening here is more of just that awareness. It's not that it's bad. It's just that think about it really hard. Maybe most patients may not require a blood transfusion.
Perfect. Thank you. There were a couple of other questions that in the chat. One of them was about how can the Bloodless Medicine and Surgery Society help to improve awareness of bloodless medicine among medical professionals in Nigeria. I think I would like to point out that with all of the talks that we have going on for this week, as well as the Bloodless Medicine and Surgery Society conference in November, that perhaps there's a lot of opportunities there to help raise awareness. And one of the questions as well was about guidance on treating Jehovah's Witness patients without blood. You did mention, Dr. Taiwo, some of those options, such as with ESA drugs, and there are some really good talks tomorrow. I'm going to do a little highlight of that, which I think might answer some questions for that attendee is there. Another question that has come in, Dr. Bloomberg and Dr. Taiwo had commented that patients in palliative care transfusion might be an option after everything else has tried. And some patients reported improvements after being transfused. If all transfusion alternatives have been tried, what factors would a blood transfusion add that could justify maybe the different reactions or perhaps those outcomes with the patients? Could you give transfusion to a patient that no other alternative treatment would help?
So when we're saying no other alternative in terms of their underlying oncologic diagnosis, those patients are generally in hospice. And those patients often do not get blood work. And so there's no real awareness of what their hemoglobin is, and they generally would not get blood transfusion. So that's a different group of patients. Patients in hospice don't go to the hospital. If everything gets managed either at home, if they're in home hospice, or if they're in a facility like a nursing home with hospice, everything happens on site, and transfusion is not part of their treatment. A patient who's in palliative care, who's getting active treatment, is not someone that would say all other alternatives have been tried. So these may be patients who are on ESAs. We do know those take a little time to kick in versus you get a blood transfusion, your hemoglobin rises right away and you feel better. So these are the patients, when you say other alternatives have been tried, it may be that they're now on an ESA, but you just started it. Their hemoglobin is 5, they're symptomatic, they are tachycardic, they are hypoxic, they have chest pain. Those patients need to be transfused, so they will be transfused. So I'm not sure if I'm answering that question. Those are the justifications for transfusion. There are symptoms that are acute. So if someone's like, oh, their hemoglobin is 6, they feel tired, they're a little dizzy, and I'm like, okay, well, you're still functional. We're gonna start you on ESAs and we'll see how you do. Someone's coming in and they're visibly short of breath, they are hypoxic, they don't look great. We're not gonna wait because that may take, a little bit for that to kick in to raise their hemoglobin. So that's kind of, those are the patients. And if we're not giving any additional cancer-directed therapy, they should be in, oftentimes will be in hospice, where we're not even checking their blood to know whether they are anemic or thrombocytopenic or whatever.
Yeah, I think this is a very difficult clinical setting where we have essentially no data to go on. But and I'm not a bedside practitioner, but a patient comes in and they're in distress. They have difficulty breathing is probably one of the most upsetting and difficult things for patients. And yes, you might start off with an oxygen mask. You might listen to their chest. You might try a bronchodilator. Depending on the clinical setting, there are many. And I'm not expert in this area, there are many therapeutic modalities one might try before transfusion to acutely help the patient, who's very in distress. But if all these things fail, or as Dr. Taiwo said, there are other reasons to think that the anemia is the contributory factor and not just the number, for various reasons, transfusion is routinely used based on a number. As to why some patients feel better, nobody has any idea, because clearly the stuff that we have in the blood bank does not improve oxygen delivery, at least for 24 to 48 hours in many cases, because it's not normal blood. It doesn't have normal levels of normal capabilities of delivering oxygen. That having been said, there may be and I'm speculating here, effects on the microcirculation just by transfusing red cells to a severely anemic patient that improves the microcirculation and relieves some of the symptoms. But that's just speculation. And we don't know why some patients respond, others don't. There's, of course, the placebo effect. The nurse says, the doctor says, this is going to make you feel better. And for a short period of time, you do feel better. And that's a very real effect. It's not, it may be subjective, but for the patient, it's very important. So I think we're in a situation where there's almost no knowledge, scientific data to guide us. And as Dr. Taiwo, you know, it becomes an element of clinical judgment of the individual practitioner. And if you got 100 practitioners in a room, you'd get 101 strategies. You know, the classic thing, which is not, it's not a criticism of physicians, it's just the reality.
Yeah.
Absolutely. I think that comment about the placebo effect is very, very key. When you hear that promotion that blood saves lives was really actually a marketing campaign before there was any, and really there hasn't been evidence to support that in many ways. And so when patients have heard that their entire lives, that is certainly going to play into that placebo effect, in addition to a nurse or a doctor saying, we're going to top you up, you're going to feel better. So that is definitely a challenge to really get good results when they have that many factors influencing that experience. Another comment was about how, you know, we have numerous options now in the treatment of our patients in terms of use of IV iron, ESA drugs, tranexamic acid, minimally invasive surgery. And the WHO has put out the urgent call for implementation of PBM, strong recommendations about it. Could the WHO do more in the area of bloodless medicine and surgery in their raising awareness about issues with transfusion and the impact on patients? Can any of you comment on that?
I'll just mention that, and this is, I know Nathaniel, Dr. Usero said he would answer this as well. In the United States, as many of you know, one of the pioneering efforts to deal with these issues was the program at Englewood Hospital led by Arie Shander and Sherry Ozawa, who found that treating Jehovah's Witnesses appropriately actually led to better outcomes, and then it extended it to the whole hospital. And so we're really kind of at the end of the beginning of this road of understanding how best to manage patients who don't want transfusion and in fact would rather die than receive transfusions for whatever reason. And mentioned in the chat is that we have a lot of mechanisms and approaches that minimize the need for transfusion. So I think the best way to take care of Jehovah's Witnesses, and in fact all patients, is to have them at a center that are used to dealing with these problems. It's like specific diseases, whether it be cancer or sickle cell anemia. If you have clinicians and teams of nurses and doctors and other professionals who are expert at taking care of these patients, you get better outcomes and you get the desired result, whether it be, you know, care without transfusion, or more importantly, the patient going home in pretty good condition and doing well.
Okay, thank you. We do have one more question that is asking about within palliative care, the practice of what might be known as euthanasia or medical assistance in dying. Can you talk a little bit about those conversations and how that might be part of a patient's care plan within palliative care?
So euthanasia is not something that is part of the conversation that's happening here in the US actively, just because it's not, at least in the state that I live in, it's not legal. But there are conversations about comfort care only. And these are patients who do not want any aggressive measures. They do not want any intervention. They made it very clear. They have capacity. And so we honor the patient's wishes within the constraints of what we're able to do legally. For patients in the hospital and they are in distress, whether it's mostly respiratory, we give morphine. Sometimes you start a morphine drip because it actually helps them breathe. So it's not an intervention to end the patient's life. It's an intervention to help with the patient's breathing, because we know morphine actually helps with breathing. It reduces the sensation in the brain to constantly, need the air. And that over time, obviously, would lead to the patient's eventual, demise or succumbing to their disease and the intervention. But in terms of actively giving a drug or an intervention to end a patient's life because of pain, that is not part of the conversation that's ongoing in many states in the US. And I think pain should not be a reason, at least from the get-go, to lead a patient to want to end their life. There's so much we can do from, in terms of pain control. So I don't think, we're going to have very many people who want to end their lives because of pain if the pain is being managed very well, if it's being appropriately managed. Now, you will have some pain where, no intervention is helpful. Those are patients that have already been plugged into, pain management. They're seeing anesthesia. They're all these interventions outside of the norm that maybe those have failed. I haven't had that experience yet, so that's not a conversation that's happening at this time.
Thank you. Thank you very much to our speakers for everything that they've shared with us, as well as everyone who asked questions. We really appreciate your engagement. I'm going to pass it over to Chris, who's got a special announcement and a request for everyone.
Thank you very much for that wonderful session of questions and answers. I'll ask everyone to hold on for a group photograph at the end after the announcement, the preview for tomorrow's program. So maybe Becky can give the preview for tomorrow's program, then we all wait for a group photo.
Excuse me, please. Becky, somebody's hand is up.
Oh, my apologies. I didn't see that. Whoever's hand is up, if you would like to comment or ask a question, I think that's Nurfeda. Go ahead. Would you like to unmute yourself? Or I'm not sure if maybe you didn't mean to raise your hand. That may be possible.
So we could go to Apostle.
Okay. All right. So without further ado, what I'd like to do is give you a bit of a highlight about what you can expect for tomorrow. We hope you will log in and join for tomorrow's program. It will start with keynote addresses by Dr. Majed Rafai, who will discuss the subject of First Do No Harm, managing hematological derangements in oncology without blood transfusion. We will also hear from Dr. Jamila Sathar, who will talk about IV iron therapy as a standard of care in oncology. And then we will also hear from Dr. Patricia Ford, who will talk about erythropoietin in the cancer patient, to give or not to give. And we will also have an industry presentation from Pharma Nutra about Cyderol, which is a new oral iron option that's available on the market. Okay, so please do join tomorrow for all of those talks, which are sure to be excellent, with some great discussion as well. Okay, so I think at this point, we are going to ask everybody to turn your cameras on so that we can take some screenshots and get a snap of everyone who's joined us today. And then whoever is taking the photo, if you want to let us know when we're done and we're okay to move on.
We have to take off the spotlights, the spotlight, so that everybody can be in the picture. So whose camera is good to take the picture with? Migo, can you help us to screenshot, please?
Yes, it's done.
Okay, great.
All right, thanks
We
all.
already have it.
Others can do so too. I will take the best shot.
But it should be in gallery to be good. It's not on gallery.
Okay. Oh, Dave, your camera, your video is not on. And Dr. Taiwo, Dr. Jadwin. Okay. One more time.
No, we're ready.
Okay, so we're done, right?
Yes, it is.
Okay. Thank you.
Okay. I will pass it back to Chris.
Thank you very much. I would like to thank our two presenters this afternoon and all the participants who tuned in. I think the numbers went up to 233, but now I think the number is about 190 for participating in today's meetings. Please, we ask for that you all tune in tomorrow for more exciting presentations. We can now close the meeting for today. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, everyone. Thanks.
Thank you. Thank you.
Thank you.
Good night.
Good
Oh,
night.
no. Good morning to you guys.
Thank you very much. Have a nice night if it is evening now.
Thank you.
Yes, very, very good morning. Thanks.
Good morning.
Bye-bye.
Afternoon here.
Night in Malaysia.
Night.
Thanks, Nathaniel. Good night. See all my more people coming.
A pleasure. Thank you, Mandy. And a big thank you to all the speakers and moderators, panelists.
Thank you.
I should stop the streaming now.